Hi everyone, welcome back. Man, this has been such an energized episode. This is the last segment, sadly. I would love to keep this conversation going as long as possible, but you know, we've heard from two amazing doctors, a radiologist and a spine surgeon who also has his hypercharge clinics, and there's just so much to talk about. You just really can't squeeze it into a couple little segments, but hopefully we'll be talking to those people again in the future. There's lots more to unearth and talk about. So this last segment we have reserved for our beautiful co-host, our guest co-host, Vicki Baldwin, who works with Echolight. And she is the person who taught me, and you know, near and dear to my heart. We're both have a background in ultrasound, and having had the option of having her teach me this technology, I mean, it just opened up all these doors for me and for us.
Indeed.
Yeah, so what we're going to do in this last segment is we're going to kind of dive in a little bit more with Echolight and with the technology, and she's going to help us and help you guys understand why this is so beneficial, why this is an amazing technology to implement into our current healthcare system. And you know, hopefully if any questions come up, you can always reach out to us offline off of this. So without, go ahead if you wanted to.
So Vicki, so you've been one of the first people really bringing REMS to the US and hence cross-border, because you trained Megan. Tell us about your REMS journey and sort of what you've seen over the course of the last couple of years, and what's so exciting, and then we'll dive into what the technology is and the benefits.
Yeah, so sonographer by trade, like Megan's mentioned several times. And you know, in our ultrasound careers, what was one thing we never scanned?
Bones. And, unless they were on fetuses.
Bones caused, traditionally in the imaging for organs, caused artifacts in the images, and we would do everything we could to work around them and avoid them.
Exactly.
I during the pandemic, I was online and kind of just happened to cross a neat little post on LinkedIn and
there
went for it, and it just was fate.
The rest is history.
The rest is history.
Or it's history in the making.
Yeah,
we're still
as a sonographer, starting for a company with a technology like this, I had a lot of questions.
Indeed.
But the image on the ultrasound screen, when you have that interface up, is it's a typical B mode image, but it's for guidance. So you're not scanning and imaging the bone. What you're doing is you're using the ultrasound image to place the proper parameters over that bone so that it can read those frequencies coming back to the probe.
That's great that you said that, because I have a lot of people come in and they say, oh, I have had a fracture, or I have this, can you check this area? And this particular unit has what we call a curvilinear probe, or it's the same kind of probe if you went to an ultrasound department and they were going to check your belly, your abdomen, look at your organs in your abdomen. It's the same kind of probe, but we have a range of frequencies that we can use in an ultrasound department, whereas with this we have one frequency, and it really just enables us to see the regions of interest so that we can direct that radio frequency to that area to draw the data from it. So it's great that you brought that up.
Yeah, so the images on this, none of the diagnostics are based off the images at all. We don't have the ability to freeze and take a screenshot of
something. Measure and all the things,
But so they're looking at the frequencies coming back from the bones, which is great because every structure in the body has a different frequency.
Yes.
So this is able to be intelligent in the way that this arthritis calcification on your spine, that's not bone.
Right.
DEXA's not, can't discern that.
Right.
So it's just X-rays are absorbed, and what goes through the patient to the plate and gets read, that's the algorithm. That's that is what gets read. So, but this can tell the difference between the two. So you're getting a true and accurate bone reading on your bone density, and not only that, but on your inner trabecular bone as well. So, it's a whole piece of the puzzle we've been missing up until about, the last 5 years or so. It was just bone density is bone density.
Absolutely.
Yep. You're either in a world of hurt or you're not.
Yes.
But we're starting to see different types of patterns to people, and it's really been neat to see how our clinicians who have been using this are starting to incorporate that into how am I going to treat this patient going forward? Am I really going to put this lady on an osteoporosis, medication when she, she has a negative 2.5 T-score, but her fragility score, which is what we use to look at the trabecular bone, it's through the roof great. So,
right.
And these are the same little ladies who are, like 5 feet tall and 100 pounds and play pickleball every day and do all the right things, and it scares them.
Exactly. Yeah. So for the people at home that don't understand even what a T-score is, let's bring it down a little bit, because speaking to physicians, which I think is amazing, I love that you actually talked about the differences between DEXA and REMS in that what this does and the technology, the way it does it, and why it is more accurate. Because we face that a lot, trying to compare DEXA to REMS. It's very different technology.
And we usually say we can't compare because they are different, but we can educate about, the differences.
And the importance of bone quality, right?
And we have many white papers on the subject and many studies that have been done. Yes, apples to apples as far as, if you're scanning somebody with no pathology, somebody that was centered perfectly and the DEXA scan was performed 100% correct, the patient doesn't have any curvatures, no rotations, then it's apples to apples. Where it's apples to oranges is when you start getting into, your postmenopausal population, who most of them have arthritis, and you have a lot of ladies with scoliosis out there that can never get a good reading. And then another great thing about this too, because it knows the different frequencies on different structures, if you've had back surgery, if you've had a vertebroplasty, they don't have a way to assess that bone anymore. This reads the bone tissue around it.
Right. So a T-score, tell everybody at home, what is a T-score?
A T-score is your score compared to a 30-year-old.
Right.
Your Z-score is going to be your score versus your own demographic. Right. So, as we get older, why are we going to keep comparing ourselves to, if I'm 80 years old, and I'm going to compare myself to an 80-year-old, well, that 80-year-old's probably going to have, an issue too. Yes. You want to compare yourself to your healthiest baseline standpoint for your demographic.
Yes. And of course, as you said, T-score relates to density, how much bone someone has, and we know we lose bone as we age.
That is the density of that outer cortical bone.
Correct.
Yeah.
But bone quality?
Bone quality is that inner trabecular bone, kind of resembles a honeycomb in the structure of it, but that is the bone on the inside that is regenerating and regrowing.
And how does it regrow? And this is where we get excited, and why having you on, and why we've embraced this technology and taken it across Canada, because of the whole preventative lens that does. What does that? What's it sensitive to? Lifestyle.
Activity, nutrition, supplementation, secondary disease processes, diabetics with the medications they have to take, really affects bone quality. You'll see diabetic people with, average to normal bone density, because the most of the time, they've been heavier set most of their lives, not most of the time, but often happens, but because of those medications they're taking, their inner bone quality is awful.
Which, if that same person had gone to have a DEXA,
they're told they're okay.
They would feel like they have this false kind of sense of security that everything's good, because they're only getting a snapshot of the quantity of bone they have, and they normally, or oftentimes, have normal bone quantity, but the quality of that bone is compromised. And so when we talk about fragility fractures, we often in our clinics have kind of steered away from saying osteoporosis or osteoporotic fractures. We talk about fragility fractures, because somebody who has normal bone quantity can have a fragility fracture, and somebody who has low bone quantity can have excellent bone strength. So when we look at those two people, just from the standpoint of their REMS results, who do we think is at greater risk for having a fracture? Well, it's the person who has quality compromised. So
And the good
that's
news
what's
about
showing.
that
Yeah.
is
Especially with low density.
Yes, exactly. Yeah.
But the good news about that is when it comes to bone quality, we can change that through adapting our lifestyle, our nutrition, our exercise, our supplementation, getting curious about the other underlying conditions that may be contributing to it so you can change that. That's in our control. That's the empowering message about REMS.
Yeah.
And that's why it's so exciting, let alone it's also 21 and older, which is really important because typically bone health is silent until it's not.
Yeah.
And someone fractures, and we're not sending people for a DEXA till they're 60 or 65. But now we can be bringing this far earlier, and our guests earlier on the show talked about the importance of that and changing the burden on the healthcare system by doing that, because people will be living with vitality instead of, limping to the end of their existence.
Absolutely. And I mean, not only, and I have 2 points that went through my brain the minute you brought them up, but another great thing too. If we're going to have to monitor these people, especially if we're trying to change things and change their microarchitecture and make it stronger, DEXA has a margin of error that, has such a range that you're really not supposed to have a DEXA more often than every 2 years. It's not necessarily due to the radiation. It's because they want to make sure that the changes they're seeing are real.
Right.
Our margin of error with this machine is so small that you can have a scan in as little as 3 to 4 months. And then going back to your point about, scanning people, starting at 21, I mean, whatever, the healthcare advocates, your family, your family,
Exactly.
whatever, is adopted, in all of these movements, let's scan, like for instance, your young female athlete.
Right.
There's pressure on them to be thin.
Yep.
There's pressure on them to work their body into the ground and
Cortisol
compete.
dysregulation because they're stressed.
And by the time they're 21, 25 years old, especially if they're vegan. I mean, just there's so many factors. They're already kind of behind the curve on the bone they've developed. So if we can catch them early and say, hey, well, this is what your status is now, you still have time that you're building bone until that age of 30 before you start to decrease. This is what you need to work on. Or, even scanning somebody at 30, there's still things you can do before you're just told by your insurance company to go to a DEXA scan and be told you have osteoporosis, and oh well, here's your prescription.
We have so much more to talk about, and we have so little time. You're going to come back on the show. And one of the things that I did want to bring up as well, because it came to my mind, is eating disorders, which, by the way, during Preventative Health Awareness Month, we have an entire eating disorder days, and we are going to be talking about REMS and the role it can play in that population as well. Just before we finish up here, the future as well, we've got a sarcopenia module coming out.
Oh yeah, so sarcopenia.
Let's talk about what sarcopenia is.
It's the wasting away of muscle.
Exactly, and we lose muscle as we age if you don't use it.
What can you not build if you don't have the muscle to facilitate loading that bone? You have to have that muscle to keep that bone strong. We're just a big, ecosystem all amongst ourselves. But sarcopenia, we have actually a pediatric module that's being close to being rolled out.
That's so exciting.
I'm from Memphis, where we have St. Jude, so I'm always kind of rooting for them. But your child oncology patients, what's it doing to their bones and their development, and or children with other skeletal disorders. There's it'll be nice to be able to monitor that. And then we have a forearm application coming out as well. So, with your patients with your parathyroid, disorders and things like that.
Amazing. Wow. Well, this has been an unbelievable show, and we have so much more to talk about. So you're going to come back. We'll make sure you're warm. Coming from Memphis, right now where it's in January, it's cold, and she's brought her sunny personality and all of her knowledge and education. And on behalf of Megan and I and the entire family. We just want to thank Dr. Sinakropi and Dr. Krishnan, and of course the Echolight team for being innovative and bringing this technology to the world. We're doing our part here in Canada. I know you're helping the US, but we're going to work globally to change the legacy of healthcare, and REMS is a big part of that. If you have any questions, reach out to us. Make sure you're following us on socials, famhub.ca, and until next time, remember, a healthy tomorrow begins with prevention today. Join the family, everybody. Stay well.